Good evening. Welcome to the December 11th, 2013 meeting of the Washington Township Healthcare District Board of Directors. If you'll join me in the Pledge of Allegiance. I
pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Catherine, if you could call the roll.
Yes. Director Nicholson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Danielson.
Present.
Director Epen.
Present.
Great, thank you very much. Our next agenda item is election of officers, and do we have a motion?
Yes, Mr. President. It's my privilege to make a motion for the following slate. Board President, Bernard Stewart. First Vice President, Mike Wallace. Second Vice President, Patricia Danielson. Treasurer, Jacob Epen. Secretary, William Nicholson.
Second.
We have a second from Director Wallace. All in favor?
Aye.
Aye.
Any opposed? Motion passes, and the gavel passes. We could change the names.
So my first official act was to drop my name tag. So I'm happy to serve in this position. I'm anxious to serve and build and strengthen the hospital wherever I can, and serve the citizens of the district. Dr. Nicholson has done a great job in this position, and I've admired the work he's done. His dedication and with a great deal of work that's involved in being president, and I appreciate all he's done.
Thank you for those kind words, Brenda. It was my honor.
So now we can move on to our next agenda item, which is our education session. And Nancy, if you could introduce that session for us.
Yes, I'd be happy to. This evening, we're going to hear from Chris Kinzel. He's the Vice President of TJKM Transportation Consultants, and he's been a consulting traffic engineer for over 40 years. His firm has conducted some 290 projects in the city of Fremont since 1974, many of them for the city of Fremont, and the rest for private sector clients. In his early career, he was the traffic engineer for the city of Hayward. We contracted for Mr. Kinzel's services with regard to our crosswalk that has been such a matter of concern to all of the people that come and go from our medical center. I thought it was very appropriate for the board to receive his report tonight.
Mr. Chair and board members, good evening. I'm very pleased to be here. It's been my privilege to work with your staff, and it's been a very good experience. We were retained, as indicated, to review the traffic and pedestrian safety conditions at the crosswalk on Civic Center Drive. That's been the scene of lots of negative situations for the users of the crosswalk and for the hospital itself. We've made studies at that location. On the screen, you can see that we made a count in October and found that there were 1,200 pedestrians just during the 14 hours represented from 6 a.m. to 8. I'm assuming that's most of them. That's a very, very high count for pedestrians at any crosswalk at any location. So that's certainly a location that's worthy of some special treatment. I think there's been some feeling in the past that what's there has been special. There's push buttons and warning signs for pedestrians. We found that when those fancy signs or pavement markings with lights on them were first introduced a few years back, they were wildly and widely received by traffic engineers, citizens, and others concerned with safety altogether. But what's happened since then, I think, is we've discovered that pedestrians feel overly protected by those devices. They're nothing but warning signs, warning devices. They don't change the legal environment for the pedestrian or the motorist. The motorists are supposed to yield to pedestrians who are in the crosswalk, and pedestrians themselves are supposed to take care when they're crossing. And so what we see is the pedestrians have placed too much faith in the signs, and I've observed that. Although many of the pedestrians there are staff members going back and forth and doing it on a regular basis from day to day, or maybe more than once during the day, there are many who are patients and visitors, and so they're not used to that. It's not a super busy street, although by channeling the traffic down to a single lane, that does present fewer opportunities for safe gaps in traffic. So the flashing warning signs that are there, if you go out there right now, they blow you away. They're so bright at night. But during the day, they're not that way at all, because the darker environment helps them. So what we found is that several very serious accidents have occurred at that location over the last couple of years. So this is a sketch that shows what's there. As you know, there's also an overpass at this location here. This crosswalk this sort of enumerates what I've just said. The pedestrians push the button and then walk on. And some of them, I've observed, don't even bother pushing the button because they feel like they're in a special protected area. They may look and not see any cars coming, but frequently their pedestrians are taking chances. And but the warning lights, which are intended to provide extra warning for the motorists at this location, for those 1,200 plus pedestrians, are not doing the job either. So there is no positive control. Pedestrians are not positively controlled. Cars are not positively controlled. They're just warning signs there that may be misleading. And I need to point out that the design of that the crosswalk and the signs and everything was built at the direction and approval of the city. So there needs to be, from our standpoint, there needs to be more done. What's been talked about is a traffic signal at that location. What's shown here in red is the layout of what the signals might look like. And by the way, our firm is working as a subcontractor to the civil engineering firm that's doing the now designing the improvements that will be done on Civic Center Drive, which will make the walkway wider, and it will formalize and make more attractive the sort of the narrowing that's happening on Civic Center. So as a result, or during this project, our firm is preparing modifications to the signals at Mallory and the modification to the signals down at the BART intersection as well. So under this scheme, pedestrians and motorists would each have their own signal phase. It would be a protected movement, so that there would be a walk, don't walk. They're sort of the symbolic version of that, a hand up. And there could even be countdown signals, so pedestrians know exactly how much time they've got. Because of the widening of the area on either side of the street, the crossing area is reduced from what it is now, and so that means there's less exposure to the pedestrians. And conversely, it takes less walk time to get them safely across, meaning we're not penalizing the motorists by having this walk signal conflicting with them. As a matter of fact, these signals, this intersection, once it's signalized, could be coordinated with the two adjacent traffic signals, so as the walk period would only come up at a time that's favorable to the through traffic, if that's desired. This is not a long, busy arterial, and most traffic turns when they get to Maury or they've just come from Maury. And so the coordinated movement is not a super paramount here like it might be at other locations. But the pedestrians and the cars would have positive control, and the pedestrians here can see the signals, and it's not like they can just come up and push the button and go on. They'd be advised not to do that. So when traffic engineers and public officials consider the need for signals, they take into account the fact that signals have pros and cons. That's right. That's the reason why signals aren't everywhere, and they're not everywhere because they cost a bit. But also there's some downside to them if they're not installed in the proper locations. Traffic signals can bring on rear-end accidents because people didn't used to have to stop there, and now they do. And when that happens, that's the kind of accident that may come up. On the other hand, signals tend to reduce the incidence of pedestrian accidents, and they tend to reduce right-angle accidents. People, in this case, coming in and going from the driveways on either side into the the hospital parking lots. So, so when considering the need for signals, the traffic engineering profession has adopted some guidelines and standards that are called signal warrants. And signal warrants are usually numerical things. You've got to have so many cars in a certain length of time approaching this, and if you have that many, you're probably better off with a signal. If you don't have that many, you might be better off without a signal, is how the warrant game goes. This location does not satisfy the warrants. There's not that much traffic on the side street, which is normally the indicator for it, and even though there are a lot of pedestrians there, they don't quite meet the warrants either. So warrants are not an absolute factor that if you meet the warrants, you must install a signal. If you don't meet them, you can't install a signal. They're guidelines, and they're advisory in that sense. And public agencies use warrants and create priority lists as a means of ranking potential locations as to when they ought to be considered for signals and when not. In this case, I'm pretty sure this location isn't on the city of Fremont's priority list. But so what happens when you don't meet the warrants? Then you have to consider other factors. Sometimes you're better off to install a signal where warrants are not met. There's been a recent example in Fremont where that took place. In fact, just a couple of blocks from here, the new Whole Foods market on Paseo Padre, north of Maury, has a new signal on Paseo Padre, and if you use that, you know that's not a super busy location. It's just a driveway, And that doesn't meet, and as far as we can tell from the record and by observing it, that doesn't meet a signal warrant either. The reason it was installed is because it was perceived, and I agree with this, to be a safer situation with a signal there than without. People would have to make a left turn out of that driveway and cross Paseo Padre traffic. And not only that, that might cause, if traffic is really busy on Paseo Padre, then traffic would back up within the lot, and that was perceived to be not a good thing either. So the city had the developer install a traffic signal at that location. I met with the city along with your attorney on November 21st to make our presentations to recommend traffic signals. They knew we were going to recommend signals. That was one of the purposes of the meetings. And I don't take it lightly that I'm recommending. I don't think of myself as the hired gun. I'm the hospital's hired gun. They want a signal, and here I am saying to the city, who I might remind you, who I've worked for almost 300 times in the last number of years. So I don't want to do something or recommend something that will make the city suspect me of not being a reasonable, ethical traffic engineer. When you get to be my age, those kinds of issues are pretty important. So we recommended traffic signals, and the city is considering that. So summarizing, I think we can all agree that the current situation is not safe. And in this case, even though those signals do not meet these guidelines, these warrants, that doesn't mean that it would be illegal for anybody to install them. They can be legally installed, and it would enhance the safety at the intersections. We're recommending, TJKM, my firm, is recommending that signals be installed at this location. I'll be happy to field some questions.
I'm sure all the board members have questions to ask you. This has been such a sensitive and difficult issue for all of us. One question that I have is, I've been told by several city people that installing a light will be more dangerous than not installing a light, that it gives the pedestrians an unwise safety feel, and so once they get a walk sign, they'll immediately walk out, and the percentage of people that perhaps run a red light are such that it would increase the danger of that intersection. I'd like to hear your thoughts on that.
Well, I think we can't, pedestrians can't just blindly cross any street anywhere, and most, virtually every signalized intersection, which is equipped with pedestrian walk signals and push buttons, that same potential is there. I don't see anything unusual about this location which would cause it to enter into the scenario where you're better off without the signal. I think right now, because it's not positive control, it's not positive regulation, almost anything that either the pedestrian or automobile will do short of colliding with one another is hard to prove that it's illegal. And so the traffic signals are much more positive. There's a direct signing and signals for both the pedestrians and the motorists alike. Some have said, well, the overcrossing there makes it a distraction, or there's other distractions in the area. I think that's true of almost every place where there's a busy intersection. And whether, but I think there's the fact that there are so many pedestrians there, it's not a rare event for a pedestrian to be there. And so I guess I'm not accepting that particular perspective.
What are your feelings about a yellow light being as effective as a red light?
Well, a
In my
yellow,
own experience, a yellow light means push on the gas, get through the intersection. It doesn't mean to me necessarily a warning.
Well-
Normally, a yellow light is it precedes a red light.
right.
And so, just a lone yellow light, in my own feelings, doesn't really signify that I ought to watch for a pedestrian.
Right. It has no, it has no special meaning. Typically, a flashing yellow or what we have out there now are installed. I mean, it does provide a cue to motorists that this is not just your typical location. But on the other hand, it's clearly not functioning well today. I understand there not only have been accidents, but there's continuing close calls, near misses. So where at the last minute, somebody wakes up and finds out they need to change their speed or their direction.
Other board members have questions?
Just a few comments and question. I would certainly agree with your conclusion that the current situation is not safe. And obviously our concern here at the hospital is the safety of our staff and our community and the people who cross the street. I want to get a little more clear as far as why you're recommending a traffic signal, what it is about a traffic signal as opposed to the current environment, which actually, in your opinion, would enhance the safety. And the two things that I've latched onto is one is the positive protected period, in that whether the cars or the pedestrians, each of them would have an interval of time in which they have the authority to go across in a legal fashion. So that's one thing that I've found from what you presented. What else do you see enhances the safety? Is it the red light versus yellow light issue? Is that we as motorists are built to respond to a red light and stop, whereas Dr. Stewart, as many of us might not respect a yellow light as much? Is that borne out in the literature of traffic safety? I'm sure traffic safety is built upon many studies and lots of data. And what kind of data is there to support the conclusions that a traffic light is safer in this particular environment?
Well, traffic engineers use a phrase that is a bit of a cop-out called engineering judgment, where you've got alternatives you can consider. And in this case, the alternatives include what's there now. Some have said, you know, if we just remove the crosswalk and remove the warning sign and make everybody feel like they're jaywalking, they'd watch out, the pedestrians would watch out for traffic, and the responsibility would be theirs. And there's some studies that have been done that show variations of that at a legal intersection crosswalk that's not signalized. There have been some studies done, and in certain circumstances, if you get that impression to the pedestrians, they actually act more safely. If they feel like they're jaywalking, they're going to look more carefully. But in this instance, a traffic signal is a normal, standard control device. What's out there at this location is not really a control device. Difference being, one of them regulates traffic and the other warns traffic. We've got warning now, and we need regulation. And so,
That's a crucial difference, of warning versus actual regulation of the
yes, that's correct. And what would happen when a pedestrian pushes a button in the absence of heavy traffic was they would fairly soon get a walk signal. But before the light turned from green for motorists to walk for pedestrians, there'd be a period of time there, a few seconds, that would, in addition to the yellow, where there would be a delay to allow for last-minute people or people who didn't see the signal. Some people trying to beat the signal, so there's a period of a dead time in there. At a normal intersection, it would be called an all-red installation, and that would be there. So there's an extra little factor of safety there, where nobody can legally enter the intersection during that time period. But I think we've sort of together we've hit on it. It's the regulation of traffic and pedestrians versus warning of traffic and pedestrians.
You alluded to the placement of the traffic light next to Whole Foods.
Yes.
On Paseo Padre, just north of Maury. And from what I understand, from what you've said, that was put in because the city thought that would make that intersection or the driveway, ingress and egress, more safe.
Yes.
Is there anything what are the differences between the situation at Whole Foods versus the situation here on Civic Center? Is there any difference that you can see which would legitimately cause the city to exercise different judgments? I'm having trouble trying to see a difference in why a traffic light here on Civic Center would make it less safe.
Well, one big difference is that is not installed primarily for any pedestrian activity. Honestly, I can't say but there's probably a crosswalk there, but it's not a main. Not a lot of people walk to the store. Some do, and so that's one difference. I think the other factor involved here is an issue called mid-block crosswalks or mid-block signals. That's one of the reasons why this location, our location, has such a negative feedback, I think, from the city and others, is that it's not a regularly spaced signal. It's not at an intersection of two public streets, that sort of thing. On the other hand, it's not an unsafe spacing of signals. You'll find, in fact, the Whole Foods signal probably a little bit further distant from the public intersection, but it's very close if it is different. But it's far enough away where the effect of one signal doesn't have to influence the other. Sometimes, you're talking, the detractors would say, well, I'm driving down the street and I'm going to see that signal at Mallory if I'm going in that direction, or I'm going to see the BART signal if I'm going the other direction. I'm just going to ignore that. Well, that's a sort of a weak argument, because that's true a lot of places, everywhere. And I think we've all had that experience maybe where momentarily that's happened to us, but that's not a reason not to do it.
Another concern I have is the city has brought up some question about the land bridge, the overhead bridge, as
Yes.
being a distraction or perhaps somewhat interfering with the safety. If a traffic signal would be put in at this area, what could be done to use the land bridge to make it more safe? Where would the lights be placed? Would it be possible to have the lights placed on the bridge or under the bridge to make it more, obviously what we want to do is, as you said, regulate the traffic and have individuals who are proceeding north or south on Civic Center actually stop when a red light occurs.
Right.
What could we do to utilize the land bridge to enhance the safety with the placement of a,
If you look at
signal
the signal drawing we've shown here, if you're coming in this direction, what's all called northbound on Civic, approaching the intersection, the land bridge is on the far side, and the signal would be in front of it. So I don't know that that's too much of a distraction. We have large signals, they're 12-inch lenses. If we need to have another one beside it to just really make it pop out, we can. I noticed tonight that that land bridge has holiday decorations in it, lights, and I was pleased to notice they were blue and not red or yellow or green. Maybe that was just coincidental, but so that's another thing you can do, is don't put a lot of red lights or green lights up there. Now, coming in the other direction is probably one that is more problematic. If you're leaving Mallory and heading toward this, will this bridge be in the way of the visibility as the motorist is coming there? And we don't think that's an issue. If it is, what we would do, we haven't got that far into it, but the bridge also is an attractive spot to hang some signals on it in advance of where you would normally put it. Sometimes that's done on curvy roads and so on. You put signals in a different spot, so there's absolutely no reason why motorists cannot see the signal display they're supposed to. We always have a signal head over on the right side, so that's a secondary head. There's one, and these are mounted low, so there'd be no question about that. And we've thought about this. We've talked about it. We haven't made any, because we don't know that we're going to be called upon to design a signal. But I'm very confident that we can put the lights out there in a spot where they can be seen and maybe take advantage of the bridge in that one direction if need be.
I've seen at some places where you will actually have in association with a signalized intersection, before that intersection, a sign that says "Prepare to stop." Would that be appropriate?
Not in advance of a signal. I'm sorry. Yes, there are activated signals where you're on a really high-speed roadway, and maybe the prevailing traffic is 50, 60 miles an hour, and in that case, you would give motorists who are about to get a red light an advance warning, and that might be prepare to stop. I'm not sure that's appropriate here. The speeds are low, and it may give it can give the wrong impression that the sign is there, the blocks are short, and the signal says go green. It might be confusing in this particular instance.
Thank you. Thank you.
Are there other questions?
I have a question. You made a statement about the lights could be coordinated or sequenced, and I'm
Yes.
assuming that's the one at Mallory. If we put one up here at this crosswalk and then down at Bart Way,
Yes.
can that be done? And I'm concerned about the time that it takes to cross the street for a senior who is not moving real rapidly, who may have a walker.
Right.
Someone may be in a wheelchair or a cane, or just simply not have the ability to walk rapidly. So can that be all factored in together?
Absolutely. Once the walk signal is there, regardless of the coordination issues and so on, they get the full crossing time. So there's no shortening of the crosswalk time, just in order to accommodate some through traffic. And conversely, when the push button is pressed and there's usually a delay. Sometimes you may have to wait as much as a minute at a big intersection before you get the walk signal. So it's not unusual to have a delay in order to make sure that this crossing period fits in with the pattern. So that's not a problem.
Okay, thank you.
Any other questions?
Yeah, hi, Chris. It's been a long time since I've seen you. Maybe 30-plus years.
Right.
And it's good to see you again. It's kind of odd to me that we hear these thoughts, not from you, that jaywalking is safer than the current crosswalk. And if you have a red light, there will be jaywalkers against the red light. Well, then I guess those folks would be safer too. But the most dangerous situation is the one we have, which is, there's no jaywalking.
Correct.
Because anybody can go across at any time. So it's one of those situations where I think we want to err to the benefit of our residents, protect them as best we can. And it sounds to me like the red light is the only way to do that. Even though there will be jaywalkers who will be safer with the red light. Yeah.
That's right.
So,
That's right.
thank you.
One question that I had was, by any chance, if you don't get the signal, traffic lights, what's the value of speed breakers or speed bumps?
I don't think first of all, they're usually not installed on a street like this because those kinds of items are usually installed in residential areas where the primary interest is keeping traffic moving at or below 25 miles an hour or maybe near a school. In this case, I don't see that speeding as the main problem. The main problem is the pedestrians and the motorists are not aware of each other's presence, or they're not taking the proper steps to get through the intersection safely. So I'm not sure that would be a good solution, a good alternative.
Are there any other questions from the board? Chris, thank you very much. You've been very, very enlightening, very, very helpful. I think all of us feel like we understand that better than what we
All right.
have before.
Thank you.
very, very much.
Okay.
Our next item is the consideration of minutes for November 13, 18, and 25, the early meeting and also a late meeting on the 25th. Do I have a motion in that regard?
So moved.
Dr. Nicholson has moved that we approve that. Do I have a second?
Second.
Finally, we have a second. Anyway, thank you very much for your motions. All in favor?
Aye.
Any opposed? That motion passes. We'll now have communications. First of all, do we have any oral communications? No name cards submitted? We'll now move on to our written communications. That's Dr. Lunny. Thank you.
So,
I'm sorry?
We do have written communication from the mayor of Fremont
Ah,
on the subject of the crosswalk.
good. If we could read that letter, that would be great.
I'm going to ask Catherine to read the letter.
Thank you. This is, to be clear, this is a written communication from the mayor of Fremont, Mayor Harrison, regarding the crosswalk.
Yes. Okay, the letter is dated September 30, 2013, addressed to William F. Nicholson, MD, President, Board of Directors, Washington Hospital Healthcare System, 2557 Maury Avenue, Suite 33, Fremont, California, 94538. Dear Dr. Nicholson, pedestrian and traffic safety are among the highest priorities for the city of Fremont. The recent pedestrian injuries at the mid-block crosswalk on Civic Center Drive as part of the Washington Hospital campus are of great concern. The city, working in collaboration with Washington Hospital, has implemented several efforts over the last year to address recent injuries at the mid-block crosswalk. Even with the implementation of these safety improvements, it is evident that the city and Washington Hospital need to work together to develop a lasting solution that is going to meet your operational needs while maximizing pedestrian safety. As noted above, earlier in the year, the city, working in collaboration with Washington Hospital, completed various safety improvements, including installing a temporary curb, reducing Civic Center Drive to one lane in each direction by restriping the pavement, creating a bike lane and additional street parking, and fitting extra flashing warning signs. We are also working with hospital staff and their design consultant to facilitate installation of the permanent curb and new sidewalk. All of these traffic calming measures have been shown to slow traffic and to discourage motorists from driving around a stopped car when a pedestrian is in the crosswalk. On Friday, I shared with you both the city's willingness to install a traffic signal, subject to the conditions we discussed, and the city's intent to seek visual safety improvements to the hospital's pedestrian skyway, which also spans Civic Center Drive, directly above the street-level crosswalk. One pedestrian injury is too many, which is why the city is aggressively pursuing permanent safety solutions to address this unusual mid-block crosswalk, up to the removal of it if deemed in the best interest of public safety. The city looks forward to continuing our partnership with Washington Hospital and to the mutual commitment from both organizations to expeditiously investigate and implement lasting safety solutions to the Civic Center Drive mid-block crosswalk. Sincerely, Bill Harrison, Mayor.
Thank you, Catherine. It's nice to have the mayor's thoughts on the subject. I think all of the board are very, very concerned about this crosswalk. One accident is too many, and we've had more than that. And we've had people maimed and injured. They will never recover completely. And it's very, very important that something be done very soon. We'll move on now to our communications from Dr. Lunny.
I'm here to report the medical staff credential action items from November. We had several new applicants. Michael Golden, MD, Physical Medicine and Rehabilitation. Ruchi Gupta, MD, Neonatology. Chelsea Joshi, PA. Rajendra Narla, Emergency Medicine. Lalithambo Venigupalan, MD, Neonatology. Stephen Prado, CCP, Cardiac Perfusionist. And Shashank Jolly, MD, Cardiothoracic Surgery. For reappointments, we had Dr. Basil Besh, Orthopedics, Dr. Robert Black, Ophthalmology, Dr. Albert Brooks, OBGYN, Dr. Mandeep Chawla, Internal Medicine, Dr. Gail Dressler, Family Medicine, Dr. Joanne Falkenberg, Family Medicine, Dr. Afshin Gayami, Family Medicine, Dr. James Hartford, Orthopedics, Dr. Mark Kuransky, General Surgery, Dr. Sweta Kausik, Pediatrics, Dr. Vinod Kurapath, Gastroenterology, Dr. David Levin, Pathology, Dr. Surjit Mahal, Family Medicine, Dr. Danny McCarthy, Teleradiology, Dr. Rashmi Patel, Internal Medicine, Dr. Huikam Fan, Pediatric Hospitalist, Dr. Mark Saleh, Urology, and Dr. Amy Toon, Pediatrics. Previous conditional reappointments, Dr. Jenny Multani, Neurosurgery, 6-month conditional reappointment, and Dr. Richard Lee, Internal Medicine, 1-year reappointment. Non-reappointments deemed to have resigned, Dr. Richard Frieder, OB Hospitalist, advancement in staff category. Joanne Falkenberg, family medicine, going from active to ambulatory status. Dr. Vinod Kurupath, gastroenterology, going from active to courtesy status. And Dr. Grace Yu, pediatric allergist, going from provisional ambulatory to ambulatory status. Completion of proctorship in provisional category, Dr. Mary Mace from thoracic surgery, going from provisional active to active. And extension of proctorship in provisional category, Dr. Richard Nguyen, surgery, Dr. Vineet Kamboj, podiatry, Dr. Elizabeth Adi, OB hospitalist, and Dr. Richard Peralta, ophthalmology. And we have one resignation, Dr. Deborah Saw, pediatrics.
Thank you. Do I have a motion on the?
So moved.
And a second?
Second.
All in favor?
Aye.
Any opposed? That motion passes. We'd now like to have our service league report from Jeannie Lee.
Hello.
Welcome, Jeannie.
Thank you. The Birthing Center volunteers have been doing a 2-month pilot just to see how it would work out to deliver snacks to the moms in the afternoons. This is brand new, and so we ran the pilot, and it was overwhelmingly successful. The students and adults that were staffing really enjoyed the experience, as well as the staff. They were very excited to see the volunteers there and just to know that their patients were getting some extra nutrition and attention. So we evaluated and decided that we are going to officially open it as a service and also expand it to pediatrics. They were feeling quite left out, and so our volunteers will be visiting the kids after moms have been served to see if they could have a snack. So that's really exciting. It's just a fun service that's very encouraging for especially our young students. Many of them are aspiring nurses and physicians, and be able to have the patient contact and interfacing with the nurses. It's really good training ground for them, and our nurses have been incredibly supportive, teaching them how to build really good working relationships with other professionals. So that's been a good experience. And then also we had our $5 masquerade sale the week of Thanksgiving. We weren't quite sure how that would work out since it's kind of a travel week and all. It was a little bit of a different time, but the community, the staff, everybody just came out and made it such a wonderful event. We did better than we did the last holiday sale, last November sale. And so our commission this year was $19,266.65. So that's all money that's coming right back to the hospital. And so we were excited about that, and everybody was excited with their purchases. And I'm sure, I'm hearing stories about jewelry showing up in everybody's home and all kinds of goodies. So we really appreciate the staff coming out and supporting us. It was a great event. Thank you.
Thank you, Jeannie. And my wife thanks you.
Yeah. I think I saw her on more than one day.
That's true. That's true. Dr. Lenny, the medical staff report.
Okay, the current medical staff has 499 members, a slight decline, 322 active status, 34 provisional, 66 ambulatory, and the rest are administrative, allied health, and professional courtesy.
Thank you. We're hovering right at that 500 mark.
Yeah, I think there might have been a little attrition because of the adoption of the electronic health record, and when some of the physicians were lower volume, came up for reappointment, probably decided not to return.
Now our hospital calendar. Nancy?
Go ahead, Joe, please.
Past health promotions and outreach events. On November 15th, the Special Olympics held a local event for high school students at Irvington High School. Washington Hospital provided athletic trainers, and Dr. Russell Nord, orthopedic surgeon, and Dr. Michael Golden, physiatrist, were on hand to provide medical support. Over 240 students with disabilities participated. On November 23rd, Washington Hospital hosted the 5th Annual Diabetes Awareness Health Fair. Dr. Prasad Kata, endocrinologist with Washington Township Medical Foundation, and Dr. Archana Bindra, endocrinologist, presented on the overview and management of diabetes. Teresa Garnero, registered nurse and executive director of Dance Out Diabetes, presented on how to stay active with diabetes. Anna Mazet, registered dietitian, and chef Alfredo Macias provided a cooking demonstration for diabetic-friendly desserts. 127 people attended the event. On December 5th, Washington Hospital held an open house for the newly renovated and expanded catheterization lab. The new biplane system allows Washington Hospital to provide Tri-City area residents with a wide range of interventional procedures right here in the community. Operated by a highly skilled, experienced team, the system uses the latest technology, providing higher resolution, three-dimensional images that enable our physicians to perform a number of leading-edge interventional procedures using a minimally invasive approach. On December 5th, as part of the Diabetes Matters program, Michelle Heading, spiritual care nurse, presented Strategies for Support, Coping with Chronic Illness During the Holidays. 8 people attended. Upcoming health promotions and community outreach events. The annual Children's Holiday Party, hosted by WIA, will take place on Tuesday, December 17th in the Conrad E. Anderson, MD Auditorium of Washington West. The event will feature entertainment, refreshments, and a photo with Santa. Attendees will have the opportunity to receive a raffle ticket for prizes if they donate a non-perishable food item for the food drive. The Washington Hospital Healthcare Foundation Report. Washington Hospital Healthcare Foundation began the holiday season with Trees of Angels for hospice tree lighting ceremonies and events on December 2nd at Newark City Hall. On Tuesday, December 3rd, the tree lighting ceremony was held at the Bernardin Family McDonald's restaurant on Mission Boulevard in Fremont. The third tree lighting event was held on Wednesday, December 4th at the Nakamura Clinic in Union City and was held in conjunction with the Union City Chamber of Commerce mixer. On Saturday, December 7th, the annual Children's Holiday Breakfast featuring Ronald McDonald and Santa was held at Washington West. The foundation provided 200 tickets that were distributed to Centro de Servicios and Canango, allowing families in need to participate in this event and have their photos taken with Santa. The event was catered by the Bernardin Family McDonald's. On Thursday, December 12th, the final tree lighting ceremony will be held at Washington West. This event will feature a high school choral competition where participating high schools including Alcyon High School, Irvington High School, James Logan High School, and Newark Memorial High School will compete for a $1,000 donation to their school's music program. The Washington Township Healthcare District Board of Directors report. In the past month, district board members represented Washington Township Healthcare District at the ribbon cutting for the new one-child office located at 1900 Maury Avenue on November 14th, Life Elder Care's volunteer recognition reception on December 3rd, and the Newark Chamber of Commerce holiday luncheon on December 5th. Washington Hospital Employee Association, WIA. WIA completed 2 collection drives. The first for Abode Services Drive for Warmth. Hundreds of sleeping bags, blankets, and jackets were donated by Washington Hospital employees. These items will be distributed to the homeless. In addition, Washington Hospital's Intensive Care Department, in conjunction with WIA, organized a drive to collect sleeping bags, non-perishable foods, towels, toiletries, cough and cold medicine, and first aid kits to be sent to the Philippines for typhoon relief efforts. WIA also donated $200 to purchase supplies to be donated to the relief efforts. Once again, WIA is supporting the 2013 Holiday Wish Tree. This year, gift cards will be collected on behalf of Abode Services and SAVE. Residents and both organizations are in need of gift cards in lieu of toys. The holiday trees are on display in Washington West and the cafeteria. Each tree is adorned with ornaments displaying what gift cards to purchase, such as Payless Shoe Source, Safeway, Target, and many others. Washington on Wheels, WOW Mobile Health Clinic. During the month of November, the Washington on Wheels Mobile Health Clinic, WOW, continued to serve community members at the Fremont Senior Center, the Fremont Family Resource Center, the Silliman Activity Center in Newark, the New Haven Adult School, and the Ruggieri Senior Center in Union City. WOW also provided healthcare services to students and families at Grimmer Elementary School and the Fremont Unified School District main office, as well as 25 sports physicals at Irvington High School. WOW provided TB skin screenings, pulmonary function testing, wellness screenings, and flu shots to various companies throughout Fremont, Newark, Union City, Livermore, and Hayward. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was November's most viewed web page with 13,701 views. InHealth, Channel 78. During the month of November, Washington Hospital's cable channel 78, InHealth, aired new programming including a Diabetes Matters program, Diabetes Meal Planning, Strategies for Success, 2 Women's Center programs, Get Your Child's Plate in Shape, and Living with Arthritis, as well as the November Board of Directors meeting. InHealth also taped a Diabetes Matters program, Partnering with Your Doctor to Improve Control, a health and wellness seminar, Don't Let Hip Pain Run You Down, and a Women's Center program, Healthy Holiday Cookies. Additional updates. Washington Hospital recently received certification for its pulmonary rehabilitation program by the American Association of Cardiovascular and Pulmonary Rehabilitation. Washington Hospital was recognized for its commitment to improving the quality of life by enhancing standards of care. Pulmonary rehabilitation programs are designed to help people with pulmonary problems such as chronic obstructive pulmonary disease and respiratory symptoms recover faster and improve their quality of life. The program includes exercise, education, counseling, and support for patients and their families. Washington Hospital's pulmonary rehabilitation program participated in an application process that requires extensive documentation of the program's practices. The American Association of Cardiovascular and Pulmonary Rehabilitation Program certification, also known as AACVPR, is the only peer review accreditation process designed to review individual programs for adherence to standards and guidelines developed and published by AACVPR and other professional societies. For more information on any of the programs mentioned, visit WHHS.com or call 1-800-963-7070.
Good morning. I'd also like to add the following news to this report. The budget that's being passed in the Senate and the House in Washington, D.C. has an agreement that sets the federal government's spending level and also provides about $63 billion in sequester relief. And this sequester relief will go until the year 2023. And this is a 2% reduction for our hospital and all the other hospitals in Medicare reimbursement that now is pretty much institutionalized. And I believe it will be part of the final package. And there are lobbyists representing the healthcare industry trying to stop this, but I don't think they're going to be able to. That's a lot of money for us. I'd also like to introduce our Employee of the Month, Vincent Caruso. He began his career at Washington Hospital in 1992. He came here working for a temporary agency. And after a month of working on various projects for facilities, his hard work was acknowledged, and he was offered a position in our laundry. He eventually became a lead in this department. And during this time, he earned his bachelor's degree from Cal State Hayward, now known as Cal State East Bay. And in 2010, he joined the materials management department as a buyer. Although well-versed in all aspects of purchasing, much of his work concerns project purchasing. He was responsible for coordinating the bulk of the purchasing for our EPIC implementation. He's currently working toward becoming a certified materials and resource professional. He lives in Pleasanton. He's married. He has 2 children. He enjoys camping and taking weekend trips with his family. He also brews his own beer and enjoys making homemade pizza for family and friends. We'd like to congratulate Vincent.
Now move on to our quality report.
Good evening. I'm Barbara Eusebio, here to report our quality dashboard for quarter ending September 2013. So first we're going to look at our core measures. As you know, these are the measures that we send to Joint Commission and to CMS on Medicare and Medicaid on quality indicators. Our first quality indicator is acute myocardial infarction. And you can see on the bar graph that we have a full year's worth of data. And as we always strive to be 100% all the time, sometimes we have a few fallouts. But basically, I think we've got this process down to a standard, and we're running anywhere between around 98 to 100%. In heart failure, the same thing. You can see over the year that we've made some progress. Again, we're running, in the high 90s to 100%. Pneumonia, this last quarter we were at 100%. So I hope that we will continue to sustain that. Our surgical care improvement project has several different indicators attributing to the care that's given to the patient preoperatively, during surgery, and then after surgery. And over the year, you can see we've made some progress. I know the physicians are working diligently on that venous thromboembolism prophylaxis. That means that the physician assesses the patient for risk of a blood clot before, during, and after surgery, and they're doing a lot of work on that, and they're making great progress. This is more of the surgical care improvement project. Again, we're getting very close to that 100%. Hospital outpatient surgery, we only have 2 indicators in this category, and the volume's fairly low, but again, we're in the high 90s to 100. So we'll move on to our infection prevention indicators. This is our central line bundle compliance. There are certain components that the practitioners have to do when they're inserting a central line, and also watching the maintenance of the line. And over this last quarter, we've been 100%. Our central line associated bloodstream infections, I'm happy to say that we had a drop this last quarter, so we are below the expected rate and at 0.73. Our ventilator bundle compliance, again, this is a bundle where the providers have to do certain elements of care when a patient is put on a ventilator, and they are 100%. To congratulate the ICU staff, they've paid much attention to this. As you can see, they've improved greatly from June. And that led us to a 0 number of ventilator-associated events in this last quarter, so kudos to them. Surgical site infections. We had 1 infection this last quarter, and we are below the goal that was set for us internally. Our C. difficile infection ratio, I'm happy to say that there's been a decrease in that also. We went from 2.4 down to 1.6. We're making some great strides in preventing and controlling that infection. Catheter-associated urinary tract infections. This one we had 1 this quarter, the same as last quarter, but it is gradually coming down. I know the nurses are working on a bundle around this infection. Our surveillance of patients in ICU for MRSA, which is one of those super bugs. We're running anywhere between 97 to 95%. Our infection rate for our MRSA was 0 this last quarter. Our VRE, another one of those super bugs, our infection was 0 this last quarter. So we move on to some nurse-sensitive indicators. Pressure ulcer prevalence study. This is a study that the nurses do throughout the hospital for each patient to determine if there are any hospital-associated pressure ulcers. And I'm happy to say this last quarter, their rate was below their CalNOC benchmark rate. Falls per 1,000 patient days. This last quarter, we had a decrease in our fall rate, and we were below the CalNOC benchmark. Moderate injuries due to falls, we had 0 this last quarter. And that's it. Thank you. Any questions?
Thank you very much, Barbara.
Okay,
Very
you're welcome.
nice report. Are there any questions from the board?
Okay.
We're all okay. Thank you. We'd now like to have our finance report from Chris Henry.
Okay, tonight we will be looking at Washington Hospital's financial and operating results for October. Average daily census for the month was about 10% below budget at 155.2. October saw admissions of 1,007. We'd expected 1,069. And patient days came in below budget at 4,810. We had expected 5,347. Outpatient observation equivalent days for October were 53 below budget at 243, and our average length of stay was 0.26 less than we had expected at 4.74. Looking at utilization, case mix index for the month was lower than we've seen for a while at 1.402, and you'll see that borne out in the statistics. Deliveries were 150 in October. We expected 171. Surgical cases were 62 below budget at 379. That included our joint cases that were 12 below budget at 137. We had 10 neurosurgical cases. We expected 28. And our cardiac surgical cases came in at 9, and we expected 14. So you see those high case mix cases being down. PTCAs for October were 38. We had expected 56. Total cath lab procedures were 64 below budget in October at 391. October had 233 vascular procedures in the cath lab, just 3 below budget of 236. So again, those vascular procedures becoming more of a factor in the cath lab. Outpatient visits for the month were 1,130 below budget at 7,842, and we're seeing that primarily in lower utilization of the outpatient lab. Emergency room was busy in October. They saw 4,309 visits. We had about 78 above the budget of 4,231. Looking at productivity, our full-time equivalents for October, productive FTEs for the month came in almost 1,266. We had 174 non-productive FTEs in the month, giving us total FTEs that were 43.2 below budget at 1,439.9. Our FTEs per adjusted occupied bed for October came in at 6.97, about 0.44 above the budget. Moving into the financials, as always, we'll look at our Governmental Accounting Standards Board presentation. This is the format that most governmental agencies use. Our total patient revenue for the month came in about 10% below budget at $170,314,000, consistent with the activity. Contractuals for the month, a little higher than we expected at 77.05, but not far off, 76.94. This was the month where we began to see our reductions in DISH. So we're going to see higher contractual levels from here on out. We are making estimates on what those are for now, and as the payments start rolling in and we get through our first cost report, we'll have a better handle on that, but I think it's pretty close to where we're estimating. So net operating revenue for the month, about 10.6% below budget at $39,264,000. Operating expenses for the month came in $874,000 below budget. That largely driven by our lower salaries and wages, which were in line with our lower FTEs, and as well as a lower bad debt provision, about $861,000 below budget. With the lower levels of activity and lower revenue, we did have a large month for benefits. We had some large claims come through, so that was an offset to some of the savings that came through the period. So we end October with a operating loss of $2.478 million. Non-operating income for the month, about $882,000, higher than we expected in the budget at $2,063,000. We did see a $867,000 unrealized gain on our investments. So we end the month of October with a total bottom line showing a loss of $415,000. Quick look at our Financial Accounting Standards Board presentation. This is the way the financial markets and Moody's may look at us. Operating bottom line doesn't change in this presentation. We pull out our GO bond revenue, our tax revenue that supports the general obligation bonds out of our non-operating income, as well as our unrealized gain. So we end up with non-operating income from a FASB point of view of $528,000 and a total bottom line loss of $1.950 million from a FASB perspective. So are there any questions on October's results?
Yeah, it appears that most of our difficulties in terms of the bottom line are occurring at the top line in terms of patient revenue or usage.
Yeah.
What are your thoughts on
Well, I think
what's going on there?
I think there's a lot of changes in the environment that are keeping people out of the hospital. There's certainly pressure from insurance companies for their patients not to come to the hospital, and that's being manifested in a number of ways, not the least of which is price sensitivity. And the plans that people are getting now have higher copays and higher deductibles. We're seeing more and more of the high deductible plans where patients are on the hook for 30%, 40% or more of the bill. So I think people are really not coming unless they are really, really sick. And we've seen that in the increases in our case mix index. It was lower this month, but overall, I mean, if you think a few years back, we were talking about case mix indexes in 1.3s. 1.4 was a high case mix index. Now we're seeing 1.5 and above on a regular basis, and that's an indication that people that are coming are sicker and have more acute issues. So I think we're not seeing a lot of those. There's also a lot of competition going in the market right now to capture patients, and a lot of the large systems like Sutter are really incenting not only the patients but their physicians to refer to those hospitals. So there's a lot of dynamics going on out there right now. And we're not the only ones in the market that are seeing these lower levels of activity. We're hearing it throughout the region. So there's a lot of pressure to keep folks out of the hospital right now. Nancy, do you have any thoughts on that?
I think the phenomenon is not just Northern California, it's national.
Yeah.
And the data nationwide is that just about everybody's census is down. I think there's a tremendous amount of upheaval and confusion around benefits. I'm sure you're more than aware of last month's big issue, which was Obama's promise if you like your insurance plan, you can keep it, only to discover that the insurance industry was canceling plans right and left. In some states, it was decided that those plans could be reinstated. In California, the decision was made by the governor that they would not be reinstated. So there are a lot of people who are changing their insurance plans right now. This is the open enrollment period, and they're trying to decide what they should be buying. And I think there are more and more employers that are going to be putting their employees into the exchange. And then you have all the confusion around the exchange. When I talk to our cardiologists, they complain that activity in their offices is down significantly. Medicare has put a very big push on controlling expenditures related to cardiac services. And so there are a lot of RAC audits. There are any number of things that the government is doing to try and squash that kind of activity. But even in the emergency room, we are experiencing a reduction in activity.
Well, I know that a lot of the effort for the Affordable Care Act had to do with trying to minimize the effect of cost shifting. In other words, the haves covering for the cost of the have-nots, which was having the effect of increasing the cost of the people that had insurance or money in order to pay for the services that had to be provided legally to those folks that had neither. So what has been our, as a result of any of the, and maybe it's probably way too new to determine this, but the effort to require that everyone have insurance.
The fines are so nominal that a lot of the population that's being targeted by the insurance industry to help float the boat, because they're the young immortals, they're low utilizers, and they need them in the equation to make this all work. They're going to gladly pay the fine as opposed to pay for the insurance product, which is a much bigger number.
What happens then when they pay the fine and then they come to the hospital?
They're on the hook themselves.
So then we would have to go after the payment any creditor would have to go after their payment.
They're individually responsible.
If they had resources.
Yeah. I don't,
what's our recent experience
most likely they don't.
What's our recent experience with either charitable care or uncompensated care?
Uncompensated care has been a huge factor. We write off, well, it used to be we'd write off somewhere between $800,000 to $1 million, and then a couple years ago it got to be pretty routinely $1 million to $1.5 million, and in this past year we're exceeding $2 million
Monthly.
monthly.
Yeah.
So that
And in relation to the cost shifting, I don't have data to bear this out yet, but when you look at this and you think about it, these high deductible plans that people are going to get on the exchanges, yes, you're going to have a lot more people insured, but the cost, it appears when you look at this, the cost shifting now is going to us, because these people are going to, the danger and the risk we have is folks aren't going to understand what they're buying, and they're going to buy the least expensive plan, not understanding what the coverage is, and they're going to come to the hospital and they're going to have a big bill and not be able to pay it. So
We are seeing more and more underinsured people.
yes,
And they end up with a tremendous bill that many of them don't have the resources to pay. So if you step back and look at this from a broad perspective, basically what the insurance industry did was take a page out of the federal government's book
Yeah,
and basically dump the cost back on the hospitals.
yeah.
Because
So-
the patients don't have the money.
So the bad debt won't be coming so much from the uninsured, it'll be coming from the insured.
The poorly insured.
The poor, yes. Yes.
And there are a lot of plans that have huge copays and deductibles to young families who have a tight budget. They're going to choose the cheaper product with the big copays because they need the cash flow in raising their family. And I've mentioned before in this forum, they have studied young families who are under the Romney Care Plan in Massachusetts, which precedes us by 3 or 4 years now. And the biggest financial burden out of all of the people that were insured in Massachusetts, the biggest financial burden fell on young families. And I think that dynamic is going to play itself out in California as well. I think where we are is all of these years of cost shifting are now going to be over. We aren't going to be able to do that. And we have started to study in our own hospital what the real cost of a patient day is. And we're going to have to do a tremendous amount of strategic planning around that and begin to shape our services accordingly. The federal government has never paid for the cost of care. Never. It is significantly under what it costs us to provide that. And now the insurance industry wants to join the government in that position. They're no longer willing to be party to that subsidy. But one of the things that just mystifies me is you have insurance companies booking record-breaking profits in their premiums collection and lower utilization, and no one's really looking at that. And they have much higher returns now than they've ever had before. They're very much in the driver's seat in the exchanges. And I think one of the unintended consequences of the Affordable Care Act is that the insurance industry now has the upper hand with the government and with the providers. It's not a very pretty picture. We're going to be paid a hell of a lot less for doing a great deal more.
And word out of Washington is they've cut us 2%
Now
already.
they're going to cut us some more.
Wow. Any other questions on our financial report? Thank you, Chris. Now we'll move on to our operations.
Okay. The month of November saw 919 patient admissions, resulting in 4,609 days of care. Our average daily census was 154. The budget for November anticipated 969 admissions and 5,043 days of care, and an average daily census of 168. So we're going to come in about 8.6% below in our inpatient days of care. The outpatient observation equivalent days were 223 compared to a budget of 338, and that's an area where we have really tried hard to gain some measure of control over how patients are put on observation status and how long they can remain there before a decision's made. And I think we're going to see those days go down, which is good because the observation payments are substantially less than an inpatient day payment. As we said before, they sit in a bed and occupy the same service as an inpatient would, but they're paid at a substantially lower rate. So we do need to begin to control that. The average length of stay for adults and children in November was lower than budget. It came in at 5.03. The preliminary information on patient mix indicates that inpatient revenue for the month of November amounted to approximately $117,950,000 compared to a budget estimate of $135,439,000. Of this amount, 58.8% was Medicare, including Medicare HMO, and 16% was Medi-Cal, including the Medi-Cal HMO patients, for a total of 74.8% in government program revenue. That's not a very favorable balance. Based on November's 4,609 patient days, 61.1% were Medicare, including the Medicare HMOs. 18.5% were Medi-Cal. The budget had anticipated that we would have 56.6% of patient days in Medicare. So you can see that the Medicare population was dominant by a considerable factor. And we expected 19.2% would be Medi-Cal sponsored. So we came in under that, which is good because Medi-Cal pays even less than Medicare, a great deal less. In terms of births, our birthing center saw 142 deliveries in November, compared to the budget of 164. They resulted in 301 baby days of care. Our newborns totaled 146, so we had some twins in there. Surgeries, we had 329 at the hospital. We had budgeted 404, so the surgical volume's way down. Cardiac surgical cases were 9 below budget. We had 5. Joint replacement cases were 18 below the budget at 106. Inpatient surgical activity was below budget by 74 cases, while outpatient surgeries were below budget by 1. 559 cases were seen in the outpatient surgery center. They had budgeted for 573. For the month of November, the total cases seen in the cath lab were 345 versus a budget of 433. This includes PTCAs that were 13 below budget at 29, cardiac catheter procedures that were 44 below budget at 82, and interventional radiology procedures that came in 26 below budget at 221. Inpatient cath lab procedures were 17 less than anticipated, while outpatient procedures were 71 less than anticipated. Outpatient visits for the month of November were 12.3% lower than the budget. The emergency room recorded a total of 3,949 patients, a daily average of 132, 229 below the budget. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,453 patients during November, only 0.8% less than the budget, so they're pretty close. Total system and emergency room clinic visits for November at 7,402. In terms of personnel, we were 49.4 FTEs lower than the budget of 1,468.8. But the FTEs per adjusted occupied bed came in at 6.79, which was above budget, and that has to do with your ability to flex down with volume. We're going to have to work a lot harder at that, and there's some departments that can't flex down. They're fixed. In summary, we had 50 fewer admissions and 434 fewer inpatient days than we had planned. Our surgical cases are below budget by 18.6%. That's huge. And cath lab procedures were below by 20%. Outpatient visits for November were 12.3% below budget. Our ER visits were 5.5% lower than anticipated. And our clinic visits for the month were below budget by only 0.8%, so the clinic visits held. Total FTEs, as I mentioned before, are below budget by 49.4%. Inpatient charges for the month were lower than budget by 12.9%. Outpatient charges are lower than budget by 8.1%. Total hospital charges for November came in below budget by 11.8%. It's a pretty rugged month. On November 30th, there were 132 days cash on hand. The total days in revenue and accounts receivable at November 30th was 68.7. The day's revenue and accounts receivable excluding Medi-Cal was 64.9. During the month of November, $1,179,691 of charges was approved or pending for charity assistance. I will tell you, the census is up in December.
I'm sorry?
The census has gone up in December.
Thank you. That's the best news we've had in the last 10 minutes.
Yeah, it's really rugged.
We now have some action items to consider. Director Danielson will present those. Number A.
Mr. President, I move for adoption of Resolution 1142, which is the Memorandum of Understanding between Nancy Farber, Chief Executive Officer, authorized representative of Washington Hospital, and the Medical Imaging Unit of 2, WU Local 6, a recognized majority representative under the terms of Board Resolution Number 331-A, effective December 11, 2013.
Do I have a second on that? Nancy, would you have any comment on that item?
Yeah, negotiations for this contract began on March 8th of this year, and additional negotiation meetings were held all through the summer and into October. This contract was ratified by the membership on November 25th, and it runs from October 1st, 2013 through September 30th, 2016. It's a 3-year contract, and it was negotiated with no reopeners. It covers 49 employees as of November, and they are mainly radiology technologists and cath lab technologists. The key highlights are across-the-board increase in January of 2013 of 2%, lump sum increases on January 1st, 2014 of 2%, and on January 1st, 2015 of 1%. There's clarification on the on-call language for all members. There's new per diem scheduling language that provides for greater flexibility in scheduling. A collaborative vacation scheduling agreement that was worked out between the Director of Radiology and the department employees. New language governing 10-hour shift employees, which states how 10-hour shift employees will be scheduled and paid. We have clarification on ETO usage so that employees who have ETO may use their ETO, and confirmation of the hospital's commitment to have student interns and that all student interns are properly supervised.
Thank you. We have a motion and a second. All in favor?
Aye.
Aye. Any opposed? That motion passes. Item B.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the bid, purchase, and installation of new sump pumps for an amount not to exceed $63,500. This equipment was not included in the fiscal year 2013 fixed asset budget.
Second.
I have a motion and a second. Nancy, do you want to talk about our old sump pumps?
This is one of those occasions where we really got our money's worth. One of the pumps that we're talking about replacing was installed with the original hospital 50 years ago. The other is over 25 years old, and these pumps activate and remove stormwater in the event of rain. Although we haven't had much rain, the first rain that we did have, we found that these pumps failed. We hope we get more rain for new pumps to handle. The cost to replace the sump pumps is $63,500. And as we mentioned, we didn't plan for this in our capital budget.
We'll indeed hope that this motion takes care of the rainfall. All in favor of that action?
Aye.
Aye.
Any opposed to that? I didn't say aye on that, and I meant to say aye, I'm sorry. That motion passes. Item C.
Mr. President, in accordance with district law, policies, and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of the Volcano IVUS system with fractional flow reserve option for the amount not to exceed $112,000. This equipment was not included in the fiscal year 2013 fixed budget.
Second.
We have a motion and a second. Nancy, would you like to explain those items for us?
In May of 2013, the board approved the purchase of one of these systems with the FFR option. It's a way of measuring I'm not going to say this in an elegantly medical way. Bill, you might want to rescue me.
It's basically equipment which helps cardiologists determine in an intermediate situation what is the right course of action to take as far as opening up and stenting a vessel versus letting it be as is. When we look at pictures in the cath lab, we only see a two-dimensional representation of something which is actually three-dimensional, and those pictures don't tell us what the full story is. This is a piece of equipment which will help us know what the true physiology and function of a vessel is and whether it requires repair. And so it will allow us to give much better care to our patients.
This was something that was recommended when we had a quality review of the department. And I think that it is a technology we want present in all of our cath labs. And as you know, we've just opened up the biplane cath lab, and I think that's room 7, the other one's room 9. I'm losing track of the numbers, but we now have 3 functioning cath labs, and we want this technology in all 3 of them. It's important because it becomes a determining factor in the course of therapy a physician chooses.
Great help to cardiologists and to patients.
Mostly to the patients.
All in favor?
Aye.
Any opposed? That motion also passes. That completes our action items for the evening. There being no further business to consider in open session, we'd like now to adjourn to a closed session. Thank you very much. We reconvene to our open session and announce that there was no action taken in the closed session. There being no further action tonight, this meeting is adjourned.